Thank you once again. It's a pleasure to be back here. I hope audience feeling sleepy, but this is a nutshell of what we do in artificial intelligence. So when you say artificial intelligence, people are always afraid that it's going to take away jobs from biologists. It's going to be a threat to our profession. But I want to give you the overall view of overview of the artificial intelligence, how it is already a part of our specialty, and how it is influencing us. So these are my disclosures. When you talk about artificial intelligence in quality and safety, there are many components to it. The first thing is, even before we acquire images, when somebody orders a study, we can use artificial intelligence right at the time. Then after we order a study, we can use artificial intelligence to figure out how best to perform a study. Then we can use artificial intelligence tools during the process of image acquisition. Then after images are acquired, we can use artificial intelligence tool to reconstruct images. Then after everything is done, when we are reporting the studies, again we can use artificial intelligence. So I'll show you different ways where we have incorporated artificial intelligence, and I'm sure you're already using this in your practice, even without you realizing it. So the most important aspect of artificial intelligence is it's a critical decision support. It is important for safety of the patients. It is important to schedule the studies. Say for example, you are all aware of ChatGPT. So if you ask ChatGPT, which is widely available all over, when should I get a CT for headaches? It gives you an answer. Suppose a clinician is a provider is ordering a study for CT scan. If he asks, okay, my patient has got headache, when should I order a CT scan of the head? So it gives very good answers. I mean, the answers are what you got from ChatGPT. It says, for routine cases, it is not required. Most of the headaches are transient, they go away. You do not have to do PET CT at all. But unless you are suspecting bleeding in the brain, blood clots, or you are thinking about tumor in the brain, you should not order a PET CT. Now, if you check these answers with what you get from ACR guidelines, you have the same answer. So you can just go to the ChatGPT, or nowadays the Google also has its own artificial intelligence program. You can just type in and say, somebody has this symptom, should we get this study or not? It tells you the answers where you should get a particular imaging study, or if that particular imaging study is not suitable, what is the other alternatives? So this is something which is already available. People use it. You may not even realize it that they are using it in a day-to-day practice. Then the second thing is, after you choose a study, when you are designing a protocol for a particular examination, artificial intelligence is very useful. For the speaker before you, Phillips, showed a beautiful example of patient reckoning that is already there in many scanners. I'll touch upon it briefly. Then it is also important to realize that artificial intelligence is being used in your bolus tracking, for your contrast timing, for your selection of different sequences for evaluation of various body parts. Say for example, we do an abdominal CT. So somebody with a routine abdomen, is there a reason to do a 3-phase or a 4-phase study? You can ask Bing AI here, ask the question, because now ChatGPT is incorporated into the Bing AI, Microsoft search engine. You can ask, do you have to do how many number of sequences for an abdominal CT? It tells you straight away one answer. But vast majority of the cases, you only have to do one phase contrast CT, photogeneous phase CT. You can do some of the sequences. You can do I minus, you can do arterial phase, you can do portal phase, then you can do delayed phase. But for routine abdomen, for most of the cases, you only have to do one contrast phase. By doing so, there are two things that quality and safety. One, you reduce the radiation dose to the patient. Two, you prolong the life of your CT tube. You are using less X-ray photons. That helps your CT also. It's a cost saving. You are improving the quality and safety, both. So here it also tells you in what particular indications you have to use multiple other sequences. Let's say when you want to use arterial phase, say when you're suspecting SCC, melanoma metastasis, or hypervascular tumors, so on and so forth. So these are the questions, these are the answers you get, and if you check with the ACR guidelines, they're exactly the same. So what I'm telling you is, already AI capabilities are there, already in your various search engines, or you can access this information as part of your physician order entry system, and you can cross-reference and ask whether this particular study is indicated or not. If you do not follow American College of Radiology guidelines, you can follow what is relevant in your particular country or geography. In Europe, they have their own set of guidelines, the European College of Radiology. I'm not sure if Arab countries have their own set of guidelines. If there are some guidelines, you can follow them also. So when you are acquiring images, either for CT or MR, you can improve the quality of exam by using various other tools which are based on artificial intelligence. I'll touch upon few of this stuff. The first thing is AI center. The gentleman from Physics 4 has shown you how it helps you in centering the patient. This is based on a camera which is mounted on the CT scanner, which looks at the patient who is aligned on the CT scan table and sees if it is properly aligned or not. There are several reference points where it can match. It is very important to have good centering of the patients to get good quality images. If the patient is off-centered, one, you get truncation artifacts where the patient should be touching the CT gantry, or because of your this off-centering of the patient, there will be uneven exposure, more artifacts, the radiation exposure will be more. These are all the side effects of improper centering. By doing these tools, you can actually center the patient, and it is much better than a radiologist actually centering the patient on the CT table. There are also tools which allow us to track the contrast. I'm sure all of you are using motor tracking techniques for pulmonary angiogram. You put the tracker in the pulmonary artery. Once it hits a optimal level of contrast enhancement, there is automatic triggering of the scan, and same thing can also be done for aorta and other vascular studies. So this is all some of the things which are already artificial intelligence enabled tools which are available, we are using, but you are not aware that it is all based on artificial intelligence. So what are the evidence for AI assisted center? One, you can save a lot of time. The technology is not wasting its time centering the patient on the CT scan table. They can be more throughput. And the centering by these tools is more superior to the centering by the technologies. The off-centering is much less. In various studies you have reported here, the off-centering is 5 compared to 19, 6 compared to 13, and so on and so forth. So to say that it saves time, it improves the quality of the exams, it also improves the safety by reducing the radiation dose. So this is before you acquire images. I'm only giving you a few examples to give you an overview of what we can accomplish using AI tools for quality and safety. Now after you acquire images, I'm a thoracic radiologist, I practice only thoracic radiology, and we do a lot of plain radiographs, especially remoteable radiographs in acute care settings. It is very easy to compromise on the quality because patients are not optimally positioned. There are so many supporting lines and tubes. It is not infrequent to have a suboptimal radiograph. Instead of telling the radiographer that this study is suboptimal, you have to repeat the study. You can use a number of artificial intelligence tools that can do a quality check right then and there to make it possible to repeat the radiograph so that it will not lose time. So several things we can do. We can look for exposure analysis. We can look for motion blur. We can look for artifacts. We can also do some image enhancement to better visualize some pathologies such as pneumothorax. So to show you the snapshot of various problems we encounter in portable radiographs, we miss the lung abscesses, which is a prominent on pneumothorax. The patient can have missed CT angles. You may miss some small pleural effusions. You may include more of the abdomen than chest. You may have underexposed, overexposed. You have all these artifacts overlying the heart and the upper abdomen, which may cause problems. There are a number of problems which we encounter routinely on radiographs. So once you train a model to look at these types of problems, which makes the study suboptimal, you train the model, then after you expose the patient, you can do a quality check using this artificial intelligence tool. By doing so, it has this heat map. It generates a heat map that tells you in this particular patient the CT angle is not included. Here, the patient's lung abscesses are not included. Here, the right lateral aspect of the chest is not included. Here, the patient's face is obscuring the upper part of the mediastinum and lung abscesses. So when the radiographer realizes the mistake, he can repeat each structure then and there itself without going back to the floor again. Because the portable unit, you can do that. And by doing so, you have one more X-ray attached to this one, where this particular area which is obscured before is cut. So you can also use AI-based image reconstruction. So in the morning I touched upon it a little bit. We talked about prefect back position, which was the day we started doing CT scans. Then we have evolved into doing iterative reconstructions. But now we have got more AI-based image reconstruction techniques. So there are several vendors. I have some experience in with a couple of vendors. We did for GE and we did for Canon. These are both FDA cleared. They are specific to their scanners. When you have, say, this particular deep learning reconstruction technique that is applied only to that particular vendor. Philips has its own stuff, Canon has its own type of DLR technique, and same thing for GE. The problem is because it is only confined to one technique, you cannot perform the study on that particular scanner. We cannot take advantage of that particular reconstruction technique. But there are also other algorithms which are available. These are vendor agnostic, that you acquire images on any scanner, then you process these images on this particular type of algorithm, then you get the same benefit of image reconstruction. So there are a number of studies out there which have demonstrated that deep learning reconstruction techniques are superior to iterative reconstruction techniques. They are costly, but they take little more time. But over time, I realized that they become faster and faster, and there is no compromise in lesion detection. So of these ones, I want to focus the study we have done. This we published in AJR, the Singh et al., and we found that low radiation dose images when reconstructed with deep learning algorithms, the image quality is superior, they result in fewer artifacts, and the noise is less. At the same time, the lesion conspicuity is not compromised, so that you're not missing any potential lesion or pathology in any of the organs. So to show you some examples here, on the top is the IR iterative reconstruction, at the bottom is the deep learning reconstruction. As you see here, the image quality is much better. These images are very noisy, very pixely. They are here much better. And when doing these deep learning algorithms, you can do various tests. So to show that the same radiation dose, DLR technique produces superior quality images. So this is another example in the thoracic inlet. We know that commonly because when you acquire thoracic images, the heads are over the limbs are placed over the head. That causes artifacts in the thoracic inlet. We have problem assessing the thyroid gland. So when you do DLR technique, this type of artifacts are fewer than the conspicuous. You can see in this technique there are lines going to these musculature. So these lines are less conspicuous. So this is something which we can do to improve the image quality. Same thing for abdomen here. Here I've showed you low dose reflex tap projection. Then I've shown you three different types of deep learning reconstruction techniques. You can choose the strength. You can choose low strength, medium strength, or high strength. Then you see that the image quality is definitely superior in all the three. And you can choose high strength or medium strength. It depends on the episode. But at the same time, the lesions are well seen, the noise is less, the artifacts are few. So these are the advantage of deep learning reconstruction. The another type of algorithm which is available is CT image denoise. Suppose you acquire images with low dose technique on any scanner. This is again a vendor agnostic that you can apply this algorithm for images acquired on any other CT scanner. When you do that, the noise is much less, the artifacts are less, and the contrast is also superior. Here I want to show you one example for pelvis. In pelvis, because of the big musculature around the pelvic bones, it produces a lot of artifacts and low dose techniques. So here the quality is much better. In the lung here, you can see the mottled appearance of the soft tissues because of very low dose technique. When you reconstruct these images with this type of algorithm, the images are much better. I have no personal experience in this particular software, but I want to show you that these type of techniques are already there. So they are not only, you should not be worried that they'll take out the arms, but they also improve the image quality and it improves your accuracy. So by the images are of good quality, you can see more details in this image. The other thing is artificial detection. Artifact detection is an example with MR. In thoracic imaging, the role of MR is not that much. We do mostly for media analysis, occasionally for lung organ characterization. These type of artifacts are more common for people who are performing more of abdominal imaging. So by doing this artificial reconstruction techniques, you can take out some of the artifacts. So this makes the lesions look more conspicuous, even though the original study was not possible. So this is another example where we are showing the PET imaging with the various type of load dose, and with this reconstruction. This is borrowed from literature. I do not practice PET imaging myself. I only help in interpretation. So this is what is possible by using these techniques. The other important thing is we can also improve the contrast constantly or contrast density after the shading is done. I have some experience with this one. We just actually published the results in various conferences. So these are the two same images. You can look at the river here. It is doing two things. One, the river appears less grainy, the images are smooth, the noise is being removed. The second thing is the contrast. The contrast in the photo grain in the aorta, IEC and all these structures is more conspicuous by doing this denoising, and also it increases the density of the contrast. So this is an algorithm which is already there. So by doing so, what is the advantage? If you thought the original study was suboptimal, which may require a repeat study, if this software is available to you, you can use this software to improve the conspicuity of the blood vessels, contrast between the vasculature. You can also reduce the noise to improve your diagnostic interpretation. So another example here is focus on these two. Focus on the very small hypodensity in the left hepatic lobe that becomes more conspicuous. The noise is reduced. The contrast in the hepatic veins is also more bright. So this is something which can be done after the images are acquired. So after you acquire images, how does artificial intelligence help you with your patient interpretation and managing your patient list? So the first is prioritize the patients. We are a very busy hospital. We do thousands of scans every day. In a busy day, we do more than 250 CT scans of the chest. That's in our division. So we're talking about many other divisions in our department. So there are literally thousands of scans which are being done every day. So and also many hospitals across the world are facing a shortage of radiologists. So in many places, the plain radiographs are not even ready. For example, in UK studies show that it takes, they have more than 30,100 chest x-rays. So you can have a type of AI algorithm which run through your list. So what this AI algorithm does is, it does not interpret anything. It only identifies a scan in which there is a potentially important or critical finding, then it flags it. Suppose the AI algorithm thinks this patient has got a fracture of the clavicle, a fracture of the humerus, or patient has a tension pneumothorax, a large pneumothorax. It identifies it, it flags it in a different color. So in a list of hundreds of studies, you directly go to that study and say, okay, this is the most, somebody flagged this as a critical finding in this particular study. Let me go and check this study. Same thing for the brain. Suppose the AI algorithm, there are many algorithms out there which are capable of identifying blood clots in the brain. So suppose that scan is done, as it is done, if the radiologist or somebody thinks that this particular scan has an important physical finding, so that goes to the top of the list, that is in red. So you get, that one gets the attention first. So this is something you can do to manage all of this. So as I said, because of severe shortage of radiologists, it is not possible to look at all the radiographs. So if you run this triaging system using some AI software, you can at least identify the scans where you think there are critical findings. By doing so, you can reduce the wait time to act upon this critical findings. So there are other techniques which are also widely available. For performing the chest X-ray, you can use this software to remove the bones from the chest X-rays. By doing so, you increase the area of the lung which can be seen without being obscured by the overlying bones such as clavicles and ribs. So a subtle nodules that things are very clear can easily be identified. That helps detection of lung nodules and lung pathology. we also have a system which we all use in our hospital. This is AI-based result subtraction. So for example, this patient has got a ground glass module in the left upper lobe. It is not so easy to see in the midst of all these blood vessels. If you take out the blood vessels here, this stands alone by itself, very easy to recognize. We use it in our day-to-day practice. By doing so, we realize that we are getting faster to picking up the lung modules. And it's also a second, suppose you do the first run, then you don't pick up some nodules, then you run the software, then you pick up more nodules. So it's almost like a secondary. It improves your speed and also increases your accuracy. Many hospitals in US have it, we also do it in our office. Then this is something which we already do in our day-to-day practice. The ribs are difficult to see on the CT scan, but by using this type of AI-based technique, we unfold the ribs. The ribs are laid out in this fashion. Not only that, it also numbers the ribs from 1 to 12. So by one go, you know that this patient has got a lesion here. It also tells you that this is the right segment, R is the right, L is the left. So this is something which is very easy to identify fractures. So this is something we have in our scanners. When images come through, we get this type of images. So quickly we look at these things and we say, what are the pathology, what is the pathology in the ribs, and what is the number of the rib. And this is something we are talking about the other day. Yesterday when we were talking with the dinner, Dr. Blah was very kind enough to take me out for the dinner and met some of the faculty there. We are wondering how is AI going to help us? AI is going to make us better. It's going to improve our accuracy. For example, say, instead of measuring, trying to figure out what is the size of the aneurysm, the AI can do all these things for you. All we have to figure out is look at these numbers, figure out if that is important or not, whether it is changing or not. If there is any other complication is there wrong with this aneurysm, such as dissection or something else. So same thing can be said for the numbering of the vertebrae. Vertebrating is laid out, we can number the vertebrae. So we don't have to waste time trying to count the number of the vertebrae. Is it T6 or T7? It is not easy always to figure out what is the number of the vertebrae. So by doing so, it labels automatically and it makes your job more easier, and we are also consistent. Suppose we all know it's T6 because it's already been done. Instead of me calling it as T6, somebody calling T5, and someone else calling it T7, we are more consistent. So by doing so, we improve the quality and we increase the safety for the patient. We also know about this type of various lung segmentations. We can quantify emphysema. Is there a clinical application for that one? We can run the software in the images we already acquired. We can quantify the amount of emphysema and we can provide the details to the clinician if that helps them in their management. So then we come to the AI-assisted reporting. So AI does all those things. So it doesn't mean that it's going to sign off the report. After AI labels something, you have to go and say whether you approve or reject it. If you reject it, the AI reading interpretation has no value. If you accept it, you are concurring with it. So you become responsible. So this is something we do because most of the AI applications right there are only to assist you. They aid in detection, they are not diagnostic. To be able to diagnose by themselves, it requires a very high standard. Most of the FDA products which are being approved right now, they are more for triage situation, where it is good enough, but it is not perfect. So it cannot replace any one of us. It will help us to make us better, make us more consistent. So we can accept or reject it. If you accept it, it comes into your report system. This is something which is more interesting because in the US, I don't know how it is done here, we dictate our own reports. So there's no typing, there's no transcription service. I look at the image, I start dictating the report. So when you do the findings section, there are now these capabilities are there in few dictation systems. By looking at the findings, it generates a conclusion or impression. So we did a study, we tried to compare the conclusion derived from the AI software based on our findings to our own conclusions. And in many situations, the conclusion or the impression made by this AI software is very accurate. This is very good for simple studies, uncomplicated studies. You do not have to waste your time first dictating the findings, then concluding and coming out with the impression. So once you do the findings, it automatically generates an impression, thereby it saves you time. Then you can always check, of course, it has. It is never 100% accurate. In many cases it works, in few cases it may not work. Suppose you describe a nodule, it has the capability of assigning a lung as category. Same thing, if you have a, suppose you, for a mammographer with a reading a screening mammal, if they say something, it has the capabilities to generate its own virus memory. So these things can be done. So these are something which are already happening. Some of them will be in the clinical practice very soon. So then after you do everything, we are reading so many cases, we are picking up so many findings, then it is also we are curious, what is the significance of my finding? I said this patient has got high amount of coronary artery calcium. I said it. But what is happening to this patient? If you have these things, there are a number of tools which can also access into your Epic system or your whatever electronic medical record system and figure out the outcomes of this case. So here one of my colleagues found out the significance of seeing coronary artery calcium on 10 milligrams, and they found that when you find significant amount of coronary calcium, it affects the long-term mortality of patients. So because AI is already there, and as time goes on, we'll use more and more AI in various aspects of our reporting, before image acquisition, during acquisition, after acquisition, then to help you in reading out the scans, and for monitoring the stability outcomes. There's so much of AI, so we should also take it because there are so many tools out there. It becomes our responsibility to develop our system to monitor the quality of the AI algorithms. If some bad AI algorithm is out there, we should be able to figure it out and say this is not working for us, this should be out. So as radiologists, we have to validate these various tools which are being developed very rapidly. So AI will play a role in quality and safety. It is already playing a big role. As I mentioned, the application starts even before you think of ordering a study, then it helps all the way through. And many of them are being FDA approved. Once in US a system is FDA approved, basically we can incorporate in our clinical practice. So this is something we should be mindful of. Thank you.
Thank you, Dr. Suma, for your informative lecture. I hope soon we could, all of us, apply these nice applications. Did you yourself are using these applications? And
some of the things I mentioned, the rate frustrating algorithm is available for this. Most likely the scanners you have, they also have the software. You should ask the vendor. If they have the software package, all you have to do is process the images to the software. It will come in your PAC system. If you have PAC system, it will come to the PAC system.
We will try.
Yeah, the vessel suppression is also we use it in our clinical system. So wherever there is a clinical application, we use them. We don't use so much of emphysema quantification because right now there is not much of clinical application for it, so we don't use it. But if somebody says tomorrow we want quantification of emphysema, we'll do it if there is a need.
Thank you. Now it's my pleasure to introduce Dr. Talal Amer, our dear professor, to talk about bronchial artery embolization.